Hello everyone, welcome in my presentation. I am Dr. Nurjaman Khan from Dhaka, Bangladesh. My today's topic is full endoscopic lumbar decompression interlaminar approach. Degenerative lumbar spine disorder is a common and significant cause of disability in the world. With the trend of an aging population, degenerative spine disorders leads to an increase to the global burden and a rise of the need for spine care. The concepts of functional preservation and enhancing postoperative recovery, minimally invasive spine endoscopic in this full endoscopic spine surgery is on a variety of spine pathology. The interlaminar and transforaminal endoscopic spine surgery have been the representatives for the full endoscopic spine surgery. Each techniques has developed many modalities skill in treating different pathologies. The interlaminar endoscopic spine surgery has further stenosis. In the early years, lumbar discectomy under fluoroscopic guidance. In 1991, Kembin developed arthroscopic lumbar discectomy through a transforaminal endoscopic lumbar discectomy. However, transforaminal is technically challenging and difficult. Evolution of interlaminar endoscopic discectomy. The evolution of interlaminar endoscopic spine surgery is based on operation of the generation endoscopic system. In first generation, 6 technique with sequential dilator under fluoroscopic guidance. At the same time, Ruden made an incision by ligamentum preservation technique of Choi was modified by Dr. Kim with serial dilators under direct visualization of endoscope. In endoscopic spine surgery, second generation endoscopic spine surgery, second generation endoscope was developed having outer diameter 7.9 mm, channel 4.2 millimeter, with instruments such as specially designed endoscopic bar pans were produced. The treatment of different levels with types of disc herniation, including level of L4-5 and above, with lateral recess decompression could also effective in this technique after developing this second generation endoscope. Third generation endoscope with a diameter bigger than second generation, that is 9.5 to 10 millimeter, and working channel diameter is 5.6 to 7.1 millimeter, was derived from the demand of effective laminotomy for effective decompression of spinal canal stenosis by the technique of lumbar endoscopic unilateral laminotomy and bilateral decompression. Indication of interlaminar endoscopic discectomy. All types of central and paracentral discs at L5S1 and L45 is easily dealt with this system. Paracentral subdiscs from L3 to L4 to L1 to L12 can easily dealt with this system. Central calcified discs L34 to L12 when planned for posterior decompression only can be done with this system. Highly migrated disc easily can be dealt with this system, as well as central canal stenosis and lateral recess stenosis can be done with this system. Even in the foraminal stenosis can be dealt with para interlaminar approach, that is it also can be done. Preoperative preparation imaging techniques. Herniation related to the nerve root should be carefully observed to determine whether to use the axillary or shoulder approach for discectomy. A CT scan is required to observe the calcification of the disc. A plain X-ray and dynamic X-ray is also the whole endoscopic system is removed and the skin is sutured. Placement of drain is optional. Usually I put absorbable hemostatic agent gelatin sponge after surgery. This is a example of L45 level discectomy. First, after landing here, at the L45 upper lamina, we land over the upper lamina, then drilling at the lower border of upper lamina, and detached the ligamentum flavum from the upper lamina there, and the portion of the ligamentum flavum is excised through piecemeal manner. And if there is any lateral recess stenosis, the portion of the facet is excised, and then discectomy is done. If there is no central canal stenosis, no need of remove the ligamentum flavum too much. Only the ligamentum flavum of the lateral portion is excised for discectomy. But in case of canal stenosis, we need to remove the whole ligamentum flavum. For the central canal stenosis, it has two technique: outside in technique, that is the ligamentum flavum is removed en bloc, but in case of inside out technique, here drilling at ipsilateral upper lamina and detach the ligamentum flavum, then the ligamentum flavum is removed by piecemeal by Carrison rongeurs. And this is a case of L45 spinal canal stenosis. We landed at the L45 level over the upper lamina, then remove the soft tissue at the level. You can see the upper lamina, and drill start at the upper lamina at the laminospinal junction. In case of canal stenosis, it needs to remove the lamina up to the attachment of the ligamentum flavum. And after the ipsilateral laminotomy, we go at the midline and continuously to the opposite side, contralateral upper lamina. You can see the laminotomy is done on the contralateral facet now, just under surface of the facet of the contralateral side. Then ipsilateral facet, drilling at the ipsilateral facet. Very minimum amount of bone is removed at the from the facet, because excessive removal of bone from the facet may lead to instability. Then detachment of the ligamentum flavum from the lamina, ipsilateral lamina, then contralateral lamina, then the contralateral facet. And you can see the ligamentum flavum is detached from the contralateral side. Contralateral lateral recess is decompressed, and the ligamentum flavum is completely detached from the undersurface of the contralateral facet. And this is the area of root exiting zone on the contralateral side. Then the lower lamina is detached. The ligamentum flavum is detached from the lower lamina. Here, during the use of Carrison punch, we are not giving any traction. We're just cutting and keep it there. If we give more traction, there will be more bleeding. Ipsilateral lateral recess is decompressed now. That is the lateral side of the facet joint, and this is the root exiting area of ipsilateral side. And just cutting the bone piece in a piecemeal manner, not giving any traction. If I give more traction, there will be more bleeding. And whole of the ligamentum flavum is now detached, and it is removed by en bloc. You can see it is removed en bloc. And now you can see there is no ligamentum flavum is there. You can see the dura, and both side of the nerve is completely decompressed now. Using radio frequency, hemostasis is done there. And now the annuloplasty is doing in the ipsilateral side. The root and dura is slightly retracted medially, and the annulus is coagulated by radio frequency diathermy. Then opposite side. This is the contralateral side. Radio frequency is used to retracting the dura. This was a case of spinal canal stenosis, so we are not going to remove the disc here. And finally, you can see this is the ipsilateral root, and this is the contralateral root, and whole of the thecal sac is completely decompressed. So in postoperative course, patient is ambulate from the day of surgery, discharged the next day. Usually I keep the patient one night stay in the hospital and give 3 doses of antibiotic. Follow-up visit is 1, 3, 6, and 12 months. I use lumbar support for 1 month and give gentle exercise and return to work after 1.5 months. There is theoretically there is a complications. Usually in practice, very minimum or no complication is there, and sometimes there may be dural tear in initial cases, but if it is very minor, can be dealt conservatively. So interlaminar endoscopy is a surgical technique for full endoscopic lumbar discectomy along with transfemoral surgery. The surgical outcome for interlaminar reported in the literature are not different from those of transforaminal, but outcomes can only be guaranteed by keeping strictly to surgical indications and correct surgical techniques. New technologies are continuously being developed, and precise systemic judgment and surgical skills are required now more than ever. Thank you everyone for your patience hearing.
Thank you, sir, for your informative and great lecture. Can you please stop your screen sharing? Before. Yes,
Okay.
thank you.
Okay.
Before the questions, I want to ask one question about, sir, what do you think about UB in lumbar stenosis? The interlaminar approach or monoportal approach is upper than UB, or what do you think?
Thank you for your question. Actually, this is UV is also a good option for canal stenosis, but I usually prefer monoportal endoscopy. I do few UV, but I am trained from the for the last 10 years with monoportal endoscopy and prefer to do these things. And one thing I can add that this is a minimally invasive surgery. So how much minimum is your surgery? That is important things. I think so. If you can do a surgery by one port, uh, I think I will not go by two port.
Yeah. Yeah, thank you.
But every surgery, including UV or distendo or open minimally invasive, everybody has giving good result, and everybody has the good compliance of the patient, and there is a lot of articles for every approaches.
Yeah. Okay, I'm going on questions. Lakush Pandey asks some questions. Dr. Han, how much minimum working channel in endoscope you require for this pathology and for stenosis?
Sorry?
How much minimum working channel diameter in endoscope you required
Okay,
for?
okay. Okay, thank you, Lapkush. Lapkush is very close to me. He's my very close friend. I am happy to see you here. Actually, I use three endoscope. For stenosis surgery, I use 10 millimeter endoscope having 7.1 millimeter working channel. But in case of discectomy only, I use a 6.9 millimeter endoscope having 4.3 millimeter working channel, so that I can I can land my working sleeve on the disc by this 6.9 diameter endoscope. When I do only discectomy in L45 and L5S1 level. But in case of stenosis, I use 10 millimeter endoscope.
Okay. Another question, which sites do you prefer for bilateral decompression if you are a right-handed person? And which kind
Yes.
of burr you prefer for laminectomy, cutting or diamond, hooded and not hooded?
Okay. Actually, I always prefer to stand on the symptomatic side. I'm a right-hand surgeon, but I always stand on the symptomatic side of the patient. And regarding the burr, always use the diamond burr. I never use the cutting burr. Because and another thing is many of our surgeon use the hooded burr, but I use the bare burr, non-hooded burr, non-hooded diamond burr.
Vehbi Gülmen from Turkey, İzmir. Do you use anesthesia, epidural or spinal anesthesia, or
Yes,
local anesthesia?
actually in transforaminal surgery, I use the local anesthesia only, but in interlaminar surgery, I always prefer to use epidural analgesia, not anesthesia. Because I can monitor the patient during surgery by moving his limbs. And for single level decompression or single level discectomy, I use the single short epidural analgesia. But in case of multiple level, I put a epidural drain there, and so that I can give more drugs up subsequent time.
Yeah. Yeah, Lavkush Pandey says UB is much more invasive than unilateral. And Ramazan Özdemir from our clinic. If the patient has an aberrant root, does your approach change?
Sorry, burden.
If the patient has an aberrant root,
Okay,
does your approach change?
okay. Sometimes very rarely I have seen there is double root there. In case of or there is the root attachment is not in the usual site. I have to recognize it first after laminotomy or after after excision of the flavum. If we not see it, we can be it can be I can injure the root. So I have seen few cases having the double root, but fortunately I can recognize it just after phlebotomy, so I can um, take care of the roots. And if there is double root, then I have to uh, go through the mm, in between the two roots. I have to go for discectomy in between two roots.
Yeah. Dr. İsmail Safa from İzmir. How many levels maximally can be operated with one entry?
Two level can be easily dealt with one entry. Actually, in young patient, I use separate entry. But in elderly patient, I can easily go through one entry. 2-3 level is also possible, but more than 2 level, I never use it. But it is a just skin incision is single, but in after the skin incision, there is two separate port inside. So it doesn't matter giving two or more skin incision, because inside there is separate entry.
Yeah. Ozan Başkurt, Dr. Ozan Başkurt from Turkey. Is there any risk of dural tear? Dural tear? Could you briefly discuss about complications such as a revision, need, bleeding, or dural tear?
Yes, dural tear is a important for the beginners. Definitely, it's a challenging surgery, especially this transforaminal, interlaminar. In case of transphenomenal, it is I never seen any dural tear, but in case of interlaminar, there is some dural tear, especially in the beginning. For the beginners, there may be every chance of any dural tear. I prefer to put absorbable absorbable substance after surgery in routinely. So if there is any uh, minor dural tear, this absorbable substance can prevent any further complications, and it is auto healed. But in one of my case in my early practice, there was a big dural tear. I convert this surgery to open surgery. So dural tear, there may be dural tear, but we have to identify it and take care accordingly. And
Okay.
dural tear may be a mishandling of bar as well as the carison pons that may be happened.
Thank you. Dr. Vehbi Gürman asks, how often do you have to turn to open surgery and in which conditions to turn to open?
Actually, for degenerative lumbar spine surgery, we can do uh, everything now by endoscopically. Even fusion is widely practiced with endoscopic fusion with minimally invasive screw fixation. So in my routine practice, I do all by endoscopic way. But for fusion surgery, I sometimes use endoscopic and sometimes open minimally invasive.
Yeah. Dr. Mustafa Arık, thank you, Dr. Han. Is there a risk to compromised stability?
Pardon?
Is there any risk to compromise the stability?
Yes, especially when we do the discectomy as well as excessive facet removal, there may be chance of instability. But in case of canal stenosis surgery, I think no need to touch the disc, only decompress posterior component and facet as less as possible, just to decompress the lateral area of the root. That is sufficient. And for canal stenosis, uh, instability is very minimum, but in case of discectomy, there may be chance of instability.
And Dr. Hasan Kamil Sucu, thank you, Dr. Han, for this informative lecture. Some people say that 7.1 millimeter working channel is too large for the stenosis surgery, and it is very difficult to pass to the distal end or to the contralateral side.
Yes,
But you prefer to use larger scope. Isn't it difficult to go to the contralateral side with this large scope?
my last video was canal stenosis. You have seen, I used 10 millimeter endoscope, and I can go the opposite side and decompress the undersurface of the contralateral facet. You have seen the video, and it is nicely decompressed and nicely shown. So The bigger scope is not a problem at all. Perhaps it is a bigger scope have some advantage, having the bigger working channel, and we can use bigger instruments through the endoscope.